Hello, so I'm going to start Plabable Gems on cardiology. And so let's start from the cardiac tamponade. So what is cardiac tamponade? It is a fluid accumulation in the pericardial space causing obstruction to the inflow of blood into the ventricles. Okay, and what are its causes? Causes are acute pericarditis, aortic dissection, and trauma. Okay, and you'll see clinically you'll see a bacterite in which there'll be hypotension, distended neck veins, there will be rest JVP and muffled heart sounds. Okay, and there will be paradoxical pulse. Okay, more than 10 millimeter of mercury inspirated drop of systolic blood pressure will be there. Okay, so it's diagnosed by echocardiography. Okay, and it is the investigation. Echo is the investigation of choice. And on ECG ECG findings will be reduced amplitude of QRS complexes and electrical ultrons. Okay, like this, electrical ultrons. Okay, so reduced QRS complexes and electrical ultrons. Okay, so you should not miss the electrical ultrons by saying that these are vibratory effects. No, you should check ECG thoroughly to exclude cardiac tamponade. Okay, on ECG. So these are electrical ultrons, not vibrations. Okay, and treatment is pericardiocentesis and IV fluid in the form of if patient is in shock. Okay, so it's all about cardiac tamponade. So let's recap backstride. It is a particularly important to remember backstride for cardiac tamponade. Good mnemonic is 3Ds. Okay, and 3Ds stands for decrease, D for decreased BP, D for distended heart sounds, and distant heart sound, and D for distended jugular vein. Okay, so there will be hypotension, rest JVP, and muffled heart sounds. Okay, so here is a case. If patient presents with a knife injury to chest and you diagnose cardiac tamponade by examination, examination finding, by observing the findings, examination finding like muffled heart sounds, distended neck veins, rest JVP, and hypotension. Okay, so this is all about the backstride and 3Ds, distant heart sound, distended neck veins, and decreased BP. Okay, and so we have done cardiac tamponade, and now start acute pericarditis. So in acute pericarditis, patient will present with the sharp pleuritic chest pain, which increases during inspiration and relieved by leaning forward. Okay, on auscultation, you'll find a friction rub. Okay, friction rub. And on ECG, there will be widespread saddle-shaped ST elevation and PR depression. Okay, and so what are its causes? Causes could be viral infection, Coxsackie virus B, and it can be developed after post-MI and Dressler syndrome and uremia. So these are the causes: viral infection, post-MI and Dressler syndrome and uremia. Okay, so here is a applicable tip. Look out for the history of a recent MI or recent upper respiratory tract infection. Okay, and treatment is NSAIDs will surface in most cases. Okay, and colchicine and corticosteroids. Okay, so it's all about pericarditis. So here is a patient will present like this, a typical patient leaning forward for relief. Okay, and your typical history will be recent myocardial infarction, recent upper respiratory. Patient may tell you that he had upper respiratory tract infection recently. Okay, and on ECG there will be widespread saddle-shaped ST elevation. Okay, so the keyword is widespread saddle-shaped ST elevation. Okay, so you can see here. Okay, so while ST elevation is widespread on all the leads, okay, ST elevation you can see in all the leads. Okay, see in all the leads except lead AVR and V1. AVR, here is a depression, and V1, there is depression. But on list of the reads, you will see ST elevation. So ST elevation is widespread on all the leads except lead AVR and V1. There will be depression. Okay, so it's all about acute pericarditis. Okay, so now let's talk about the cardiac murmurs. And so if there is cardiac defect, so associated murmur will be audible by ear. Okay, and in mitral stenosis, mild systolic murmur at the cardiac apex. Okay, so you should keep in mind that mitral murmurs will be audible at the apex. So if patient develop mitral stenosis, so he will have mild diastolic murmur at the cardiac apex, and it is associated with snapping, opening snap. Okay, and in mitral regurgitation, it will also be auscultable at the apex, but there will be pansystolic murmur at the apex radiating to the axilla. Okay, or regurgitation or radiating to axilla. Okay, and so now let's talk about the aortic stenosis and aortic regurgitation. In aortic stenosis, there will be crescendo decrescendo systolic murmur, ejection systolic murmur, aortic S stenosis, S systolic murmur. Okay, and aortic regurgitation is diastolic decrescendo murmur, bounding. There will be bounding pulse and wild pulse pressure. Okay, so now let's talk about the cardiac murmurs. So you should know the normal to exclude the abnormal. Okay, so normal will be audible. The first sound will be at the start of systole and at the start of diastole. It is normal, but if murmur is audible throughout